Hi, my name is Fausto Pinto from Lisbon, Portugal. I'm the immediate past president of the European Society of Cardiology, and I'm delighted to be here in Orlando for the meeting of the American College of Cardiology. And it's my big pleasure to have with me two distinguished colleagues from the local team, Dr. John Jarko and Dr. Lynn Werner Stevenson.
Afternoon.
Both highly experts in their fields, and it's going to be a good discussion now on some of the topics that were presented today here at the Congress. This is the third day of the Congress, but there were quite exciting studies. One of them was the CANTOS study. It was a sub-study of the CANTOS, which is a study that really brought inflammation back to the arena in the acute myocardial infarction and coronary artery disease. But today was looking at a specific subset of patients, patients with diabetes, and actually looking at the issue of diabetes, and it brought some interesting results. Do you want to comment?
Sure, absolutely. So this was a pre-planned sub-study from the CANTOS trial. The main primary analysis of CANTOS, of course, people will remember, was a cardiovascular outcome, looking at the effectiveness of canakinumab in patients who'd had an MI and who'd had an elevated CRP, and it showed that they had a reduced cardiovascular event rate. But the investigators had a pre-specified additional hypothesis, which is the possibility that canakinumab might reduce the rate of incident diabetes in patients who were pre-diabetic at the time they enrolled in the trial. And there is actually a biological rationale for this idea. There's a strong correlation between inflammation and beta cell function and insulin resistance. And there's evidence to suggest that in patients who have chronic hyperglycemia and who develop amyloidosis of the islet cells, that there's an inflammatory response. So there was a logic to this approach. The thing that was interesting about it was that it was very clear that higher inflammatory marker levels predicted the onset of diabetes in pre-diabetics in the study, and it was clear that canakinumab reduced those markers, and yet there was no reduction in the incident diabetes rate with canakinumab compared to placebo.
So how do you explain that? Or
Well,
what's your theory?
It's a really good question, but I think there are a couple of thoughts that we have about this. One of them is that yes, inflammation plays a causal role in the onset of diabetes, but it doesn't go through the interleukin-1 beta pathway, which is the one that's inhibited by canakinumab. And so then if we think that's the explanation, we might think about other pathways like tumor necrosis factor as a possible pathway to try to manipulate in patients who are pre-diabetic. Of course, the other possibility is that inflammation is a marker, but it's not causal.
Absolutely.
Yeah.
There was a concern also, and there was actually in the discussion about infection and the potential percentage of patients that could actually develop fatal infection in this kind of treatment. Do you have any comment on that?
Yeah, so even in the main trial, of course, there was evidence of an increased rate of sepsis and of serious infections, and this too was confirmed. And of course, you worry particularly about that in patients with diabetes, since they're already at increased risk of infection. There wasn't an incremental increase in the risk of infection, but canakinumab, even if it had been effective, might not have been a very good drug for that patient population. So I think there's a lot still to be learned about the relationship of inflammation to diabetes and whether that's a suitable place to intervene.
Good. The other interesting study was a study on hypertension, and actually that's one of the areas where we all feel that there's a lot to be done. And this was really remarkable. It was a very special kind of study that I would like you to comment on, the barbershop, how we can do work closer to the patient and how that can have an impact on the way that we can improve patient management in hypertension. You want to briefly describe the study?
Sure. So the investigators had an interesting hypothesis here. They were very concerned about the fact that there's a particular segment of the population, particularly in the United States, that being black men, who have particularly difficult time with controlling blood pressure. They have high blood pressure, it's poorly controlled, and they tend to have fewer physician encounters than many other segments of the population. And so there was concern that some of the problem with the control of blood pressure in this segment of the population might be related to the interaction between patients and the healthcare system. And so they had the novel idea that rather than requiring the patients to come to them, they would go to the patients. And the setting they chose to go to the patients in are barbershops, which, as it turns out, for some members of the black male community, is a social setting as well as a setting for getting a haircut. And so they did a cluster randomized trial where the unit of randomization was the barbershop, and several barbershops were assigned to the intervention group and other barbershops were assigned to the control group. And then the men who came to that barbershop, who were regular clients, who were coming regularly, would be evaluated by a pharmacist who would measure their blood pressure and who would prescribe blood pressure medications under an agreement with a physician, and would also recommend lifestyle changes and would also measure electrolytes with a point of care device. And what they demonstrated was that in the intervention group, compared to control group that was just getting really advice about blood pressure, there was a very substantial reduction in blood pressure. They had a 22 millimeter of mercury differential between the benefit in the people who were treated and the benefit in the people who were in the control group. And that is a reduction in blood pressure we have not seen in blood pressure trials. So for all the new drugs that you can think of that might produce an incremental benefit, here's an increment that just is enormous.
So do you think this study is going to make it to the guidelines?
Well, so it's a very interesting idea. One of the questions that one of the discussants had was, so what's the cost for this? And they're still analyzing that. And I do think it's possible that that could be an obstacle. But it does raise the question of whether what we need to do, maybe not just in blood pressure control, but in other areas of medicine, is to get out where the patients are and to start maybe thinking about clinics in churches and clinics in football stadiums and clinics in shopping malls, in places where instead of making the patient feel that they're stepping out of their daily life to come and see us, they can be doing it as part of their daily life.
And it certainly challenges the current paradigm on how treating these patients, which has not been perfect, so we need alternatives, and this certainly is a good...
Well, I have to say, I'm thrilled by this because increasingly we're recognizing that hypertension is the main modifiable risk factor that leads to heart failure, which is, of course, what I take care of all the time. So if we can improve our therapy of hypertension, I'm going to have fewer patients to take care of, which would be really good. So this is really exciting to me because we can finally get prevention into heart failure therapy, but it's also exciting to me for a larger reason, which is that I think it's not just hypertension. I think it's all of medical care. We need to make this be a community effort where people want to support the other people in their community.
Absolutely.
Not just to have a one-on-one relationship with their physician, but to care if their neighbor's blood pressure is controlled, to care if their neighbor is taking the right medicines for their heart failure. And I think it gets back to the old idea, if it takes a village, it may take a barbershop.
It certainly is another way.
I'm very excited about a positive trend that we can identify here.
But let's focus a little bit now on heart failure. There were a few trials presented today. One of them was the Ferric-HF and the whole wall of iron in patients with heart failure. And the results were quite interesting. Do you want to comment on the trial?
Well, the issue of iron, the European group has really led the way in demonstrating to us that replacing iron in people who have heart failure really seems to improve exercise capacity, even in patients who aren't anemic.
Yeah.
Because the iron itself is involved in these key enzymes that relate to the energy metabolism directly in the muscle. And a number of very important trials in Europe have shown us this, but what we saw today was a beautiful, small physiologic study that was so elegantly designed, looking at the metabolism of phosphocreatine and the recovery of phosphocreatine after exercise, which actually gives us something to measure, which is that the recovery of the high energy compounds after exercise was higher within just 2 weeks of IV iron. Which I thought was just a beautifully elegant physiologic study that I think will help us understand better how to use iron to improve exercise capacity in heart failure, because we obviously worry a lot about hospitalizations and mortality in heart failure, but patients want to do more. And so I think this is an exciting way to understand a little better how the iron may be working in these patients.
So do you think it adds some more information in terms of increasing the indications for iron therapy in patients with heart failure, or what's your view?
My view is that that body of evidence is just getting higher and higher, and in the European guidelines it's already a higher level of recommendation than in the US. to be treating heart failure patients who have iron deficiency, and I'm hoping that this will help us catch up to you.
Finally, there were also a couple of studies on imaging, one on CT, the other one on MRI, in heart failure. So how do you see the role of imaging and how these two trials can actually add a little bit in terms of how much imaging can help to understand better?
Well, I think the focus was an unusual focus, which was not on the chronic care of heart failure, where we think of all the expenses and the morbidity, but on the diagnosis of people with new heart failure. And it was looking at CTA instead of doing invasive coronary angiography and looking at MRI. And they were complex studies, which I would say in a way are really pilot studies done between Canada and Finland. And they looked at how we make decisions about when to use these expensive technologies. And I think the conclusions, I would say, we can't really say affirm from this, but they do raise this question of how we should be individualizing care for people who present with new onset heart failure as to the most likely diagnoses, and to focus on what therapies or what therapies do we have, so because that helps us decide what diagnoses to make. And I think the issues of inflammatory heart disease, amyloid heart disease, occult ischemic heart disease, these are things we need to think very carefully about in every new patient who presents, because it's worth a lot to be able to find a treatable cause in someone who presents with heart failure.
Yeah. Well,
did you get the sense that there was a targeted approach that might be implemented based on some of the work to suggest who's the person who's most likely to be a good candidate for imaging, or how do we decide when somebody should or should not be imaged?
Well, I think everyone should be imaged with echo. I don't think anyone disagrees with that. The question of when to go on to MRI, for instance, is when there's a specific additional diagnosis that would influence your treatment. And the other, as far as coronary artery disease, it's so prevalent that I think it's difficult to say that we would ever not do some tests to look for coronary artery disease in someone who presents with heart failure.
But also do better patient selection.
Right.
I think that's one of the key issues. Well, we could be here the whole day discussing some of the beautiful results that we had during this Congress. I want to thank you for being here with us with ESC TV. And again, this was the end of the third day of our Congress, of this Congress of the American College of Cardiology in Orlando. Some news, some novelties that will improve the way we can do patient management. Thank you.
Thank you very much.